So, what is jaundice?
Observable yellowing of the skin.
Yellowish discoloration because of elevated bilirubin more than.
I think the Malaysia guideline is 20 to 30, but the international guideline writes 80.
Yeah, 85 will be visible lah. Kalau less than 80, it's not visible. It's just elevated bilirubin, not jaundice. Okay. So if you talk about phototherapy and all that, it's always the neonatal jaundice less than 2 weeks lah. More than 2 weeks, prolonged jaundice, even it's high, we don't really start phototherapy lah. Okay. So when we talk jaundice that requiring phototherapy, I need you all to tell me 5-ish what are the causes of jaundice. Polycythemia is fine. Okay, then we talk about the blood disorders lah. Okay, one of it is polycythemia. Why polycythemia easily get jaundice?
Because there's too high red blood cell count to breakdown of it.
So it's related to the amount of your red blood cell count lah. More red blood cell, then your baby's red blood cell easily break down after 1 week, 2 weeks. So when they break down, it release your heme and bilirubin lah. So your bilirubin will rise up because of it lah. Child is polycythemic lah. The level was 67. So what is the cut-off point to say is polycythemia in babies? Don't know. Not reading enough. 65. Less than that is not polycythemia lah. Okay, I'm not going to talk about polycythemia anymore. We're talking about jaundice. So first, okay, that's baru one. Another more causes of jaundice.
ABO incompatibility.
Yes, ABO incompatibility. So what are the features suggestive? What are the history that suggests this patient, this baby can have ABO incompatibility?
Mother is O positive.
That one is reverse. ABO is ABO.
Mother is O positive.
Okay.
And the child is
Different blood group lah. Okay. So if you know, if they convincingly, they for sure they know father is also O, most likely baby is O lah. Okay. Cannot be another thing lah. But father is A, can be still O, can be that A blood group lah. Alright. So why mother's O blood group, baby's different blood group can have ABO incompatibility?
because O blood group has antibodies to has anti-A and anti-B antibodies. And when there is mixing of blood, let's say with the baby with blood group A, who has the A antigens on the red blood cell, the anti-A antibodies will react.
So when is the mixing happen? Mother's blood and baby's blood?
During labor, during delivery.
Yalah, during the transfer, because they are connected with the umbilical cord, right? So when they cut the cord, some of the mother's blood also transferred to the babies lah. So that's why you will get the ABO incompatibility. Most of the time will happen within 24 hours lah, up to day 3 lah. Rarely up to day 4, day 5 lah. Okay, so usually within first 5 days tu, it still can be the younger they are, more likely is ABO lah. But the older they are, less likely already. Okay, I will not say it cannot, but less likely. Okay, you will think about other causes rather than ABO lah kalau already day 4, day 5, day 6 onwards. Okay, so day 1, day 2, day 3 still can be ABO lah. It will take a bit of time for the mother's blood group O to completely go away lah. Okay, alright, next blood related causes sama. HSPD. Okay, so baru part 3. Alright, you mentioned another 4 lah, reasons. Okay lah. So reasons in the cause. Okay, so G6PD need to know very well what are the pathophysiology. What is G6PD?
6-phosphate.
What does it do? What does it do? You talk about G6PD, then don't know what is the function of G6PD. G6PD is your red blood cell membrane stabilizer. Okay, it stabilizes your membrane from breaking down. Okay, so when it becomes deficient, so your RBC blood cell easily lies lah, because they don't have, it's not very stable. Okay, so When not stable, easily jaundice lah. Okay, so the problem with speedy deficient, we don't know when the red blood cell gonna lyse. Can happen day 1, can happen day 2, can happen very acute. So that's why babies GCSP deficient have very high risk of developing severe jaundice in a very short space of time. Okay, so that's why we keep them 5 days in the ward. Right, cannot go back. 5 days to monitor in ward, because anytime they can have hemolysis. You don't know. So you also need to review baby at least twice a day, morning and night. AM and PM lah, to see baby jaundice or not. Kalau nampak jaundice, take the blood, see the level, start phototherapy. Even need phototherapy, when you off it, cannot discharge yet, you still have to monitor, repeat blood every day lah, to see another episode of lysis or not. Okay, so GCSPD, what are the method lah, mode of inheritance? Sling. Okay, only boys get it lah, girls can get it lah, but very rare, in a process called lionization lah, some genetic mutation. So we need to advise parent to check every day, 5 days, even after discharge, after day 5, day 6 too, they still have to monitor every day jaundice lah, because it still can last at day 6, day 7, even up to 2 weeks of life lah. So 2 weeks of life, prolonged jaundice pun, one of the causes of prolonged jaundice is GCPD deficient. Okay, alright, so resist immunization.
When the mother is rhesus negative and the baby is rhesus positive.
So the problem will be at the first pregnancy or second pregnancy. Why?
Because from the first pregnancy, when there's mixing of the blood between the mother and the child, there will be the antibodies created.
So especially when there is antepartum hemorrhage, history of the mixing of the blood, so there will be antibody production lah, the sensitization, all those things lah. So that's why you need to give rogum lah. So rogum kind of like counter all this process lah, so prevent second baby getting attacked by the antibodies developed during the pregnancies lah. So usually the second child usually get the worst of it lah. But most of the time, the problem of rhesus is not a problem anymore, because we screen the mother's blood group and rhesus blood group during antenatal booking. So everybody knows their blood group. Those with negative, they will monitor, they will give rogum. At 28 weeks, I can't remember lah the thing. So the occurrence of rhesus is not very common anymore. I probably see one or twice for the past 14-15 years. Those because mother not following up lah, tak follow up. Okay, alright. Okay, so 5 already. Next.
The infection.
Yeah, inilah sepsis lah. Like that baby in the NICU just currently under phototherapy. If I ask you all, what is the probable cause of the jaundice in this patient? Most probably sepsis lah. So patient sepsis will become jaundice lah. It's basically a defensive mechanism. If you see all the septic baby, they will jaundice very high. It's probably part of the defensive mechanism lah, so that people will notice baby is unwell. One of the signs that people can notice lah. Yeah. So when you see baby jaundice, you need to find out lah, baby is well or not well. Baby is well, that's fine lah, look for other causes. Baby not well, you see lah, baby feeding not good, looks very lethargic, all those signs lah. So there will be other signs lah on top of jaundice lah, because of sepsis. This baby got thrombocytopenia, I don't know lah. Okay lah, maybe send blood culture, got grow something, the MBC, high white cell count on top of the thrombocytopenia. If send CRP will be high lah. Okay. Next, what are the causes of jaundice?
Enzyme deficiency.
What enzyme?
Criglia largina.
No, don't talk about all those funny thing first. I don't like. I have tak pernah tengok pun. So okay.
Breastfeeding.
Yes, breastfeeding jaundice. So what is about breastfeeding jaundice? Very favorite topic to us.
And the baby is not drinking,
So what are the clinical problem of breastfeeding jaundice? What causing the jaundice? I know the name is breastfeeding, but what is the clinical problem that causing the jaundice? If you don't drink enough, what happen?
Not enough extra.
Don't drink enough, what happen to your body? If you all don't drink enough, what happen? Dehydration lah. So the main reason for the jaundice is dehydration. So even though the name is breastfeeding jaundice, the cause is dehydration. Okay. It's just mild dehydration. You can call lah breastfeeding jaundice. So in the end, objectively, you want to know how much is the weight loss. So maybe easy. Got birth weight, got weight during arrival, admission, whatever. So you can count the weight loss. So ada patient AGE a bit difficult lah because you don't know. Patient AGE, diarrhea, vomiting, you don't know how percent weight loss lah because no one monitor weight daily when they big already, right? Babies monitor weights daily. So you know the weight, birth weight, you know the current weight. So you need to count how much weight loss in the newborn. Okay, so you need to know also the normal weight loss in babies, especially the first week of life. First week of life, how percent?
10%.
No, they should not proceed more than 7%. Okay, alright. If anything more than 7%, I think it's dehydration already. Okay, some take 10% lah to say is needing intervention lah. Okay, alright. So kalau weight loss 8, 9, 10% already borderline like that, and then you need to know the breastfeeding history properly. So how do we ask breastfeeding history?
How many times?
Yeah, okay.
Lunching technique.
Okay. Some more?
How long does it mean?
How long does baby feed? Okay.
The amount is
The amount is not something you can easily ask lah, but you can ask the mother. First, how much the mother think the mix she has lah. Ask mother, does she has a lot of milk or not? Usually day 1, day 2, not a lot of milk, especially in primates. Primigravida more likely to have less milk production, more likely to have problem with breastfeeding lah. Okay, does baby latch, baby suck well or not? Okay, if baby sucking well, how long does baby suck? If baby suck and become content, means become full, by 15 minutes they should stop feeding already. But if they continuously sucking, 1 hour still sucking, you know it's baby not getting enough milk. Right, that's one thing lah. And can ask the mother if breast milk is a lot, whether they feel difference or not after baby feed. After 15 half an hour tu, does it feel lighter or not? Okay, usually they can tell. Okay, on top of it, how you gauge baby drinking enough is based on the urine lah. So how frequent baby pass urine? If baby pass urine regularly after every feed, you know lah baby drinking enough. If baby change pampers 2 times, 3 times a day, not enough lah. Usually they should pee every feeding lah. If they feed 8 times per day, they should pee 7-8 times per day lah. Okay, alright. So the weight loss, if anything less than 7%, I don't think about breastfeeding lah. It's normal weight loss in the first 1 week of life. They should gain their weight back after 1 week lah. At 1 week of life too, they should gain their birth weight lah. So if you see they don't get the birth weight or not reaching near enough to the birth weight, you know baby is not drinking enough lah. Okay. Alright, another thing about the pampers, when you check the diapers, the color of urine. If color of urine very concentrated, not enough milk. If got urate crystal, not enough milk. What is urate crystal? Never heard of it. Urate crystal. There is orange tinge of streak of colors on the pampers lah. If you see orange discoloration on the pampers, it's urate crystal lah. It means the urine is very concentrated, it become crystallized. So it looks orangey. Alright. Okay, that's about breastfeeding lah. Okay. What is the difference with breast milk jaundice?
The difference with breast milk jaundice is that the jaundice is caused by the breast milk itself.
Okay.
Breast milk jaundice.
So, what are the features compared to breastfeeding?
Adequate amount or adequate feeding.
So, if baby drinking adequately, how's the weight gonna be like?
Maintain or maintain.
They should gain weight lah, or mean good weight gain. Okay, alright. Then they should pass urine a lot. Okay, and then is one of the causes of prolonged jaundice as well lah. It can be one of causes, neonatal causes jaundice causing needing phototherapy as well lah. But quite rare also lah needing phototherapy. Okay, next, what is the other causes of breast neonatal jaundice? Baru berapa ni? 7. I need 15. Can, but I want we discuss prolonged jaundice. Okay, sama. Because biliary atresia, they don't present at 1 week or 2 weeks of less than 2 weeks of life. It will present a bit later, but there will be sign, because baby with biliary atresia will have other causes of jaundice as well before they develop biliary atresia. Because biliary atresia is not something you born from day one, you already got BA. It's progressive cholangiopathy. Mean your biliary tract is still there to a certain extent, but over time it get worse, it get more narrow until it become fully obliterated. So that's why it's progressive. So that's why you get biliary atresia first 1 week of life lah. Okay, you only do prolonged jaundice. The main thing you do prolonged jaundice is to look for biliary atresia lah. But if causing baby to need phototherapy, I don't think so lah. Okay, but the signs that patient have possible underlying biliary atresia, you need to see the breakdown of your bilirubin level lah, your direct and indirect. The direct component will be on the higher side, but if patient also have the other cause of neonatal jaundice, like whatever it is, ABO, whatever, you see the total number is still about 300, something like that. Usually it's about 10% of your total, your direct. Mean around 30 should be your direct lah. Okay, somehow those will be biliary atresia, the percentage is a lot higher lah, 15. And then as the biliary tree become much narrower, you see the percentage will increase over time lah. Okay, so you see the percentage is a bit off, like more than 10%, 15%, 16%, almost 20%. You probably need to give appointment follow up lah once the bilirubin level go down. Once they can off phototherapy, you still need to follow them up and monitor the direct component lah. Okay, so more than 15% we are quite cautious already. Okay, more than 20% definitely you have to work up something towards surgical causes already. Okay, so next, what are the causes of neonatal jaundice? Baru 8. Some more. So prolonged jaundice. Some more. Prolonged jaundice, not first 1 week of lah. They all don't need to phototherapy one lah, all this.
The abnormal red cell shapes.
Yeah, can. It also can be part of your prolonged jaundice, can be the causes of neonatal jaundice. This one is hemoglobinopathy of membranopathy lah. So it probably part of your GCSPD group as well lah. If patient also have underlying thalassemia, very strong also, easily breakdown, RBC breakdown, same result lah. same like GCSPD. So another thing is don't forget about minor blood group. ABO is your major blood group. Rhesus is your major blood group. There is minor blood group also. There will be incompatibility as well. So minor blood group like your Cal blood group, Duffy, Delta, you check lah all those minor blood group. We won't screen, but if you see patient into jaundice, somehow you do the ABO blood group match. Somehow retics high and then HB on the low side. So you probably have to suspect this minor blood group lah. Maybe mother B, baby B. Then mother O, baby O. But somehow retics on the high side because they cause hemolysis as well. Right? So then you see retics high like that, then if you send full blood picture, you see evidence of hemolysis, then you can suspect lah possible minor blood group. So in ABO as well, when you hemolyze, your retics more than 5%, HB low, like less than 15, I would suspect blood group hemolysis problem lah. Kalau got exact cause like ABO, yes lah, you know already lah, but somehow the blood group match, but somehow retics high. And you see SN MVP, later on lah, it's not immediately you get the result. Okay, so minor blood group is one of the causes lah. Alright.
It will also occur very fast, like ABO and rhesus.
It can happen within first 1 week lah. Okay, but I think ABO is most likely to cause the acute first 24 hours one. Okay, the first 24 hours jaundice usually the ABO, GCSPD, and then sepsis lah. Okay, usually those three lah. Alright. Okay, some more. What else? Cause of jaundice. Still problem jaundice. Suka bagi problem jaundice punya causes. Baby NSU, a lot of baby prime, right? Can prime cause jaundice? Yeah, premature also is one of the causes of jaundice lah. Because you got risk factors already. Prime baby is small. You have small containers, level easily become high lah, compared to those big containers, 3 kilos, 4 kilos. Alright, that's one of the reason lah, because they are small weight. Less than 2.5 kilo, they are all at higher risk of developing jaundice, much easier than the bigger counterpart babies. Okay, kalau small for gestational age babies, even though term, same risk as prime babies because they are small. So if you have 300 level of bilirubin in 3 kilos and 300 level of babies in 2 kilos, which one we has percentage of higher per BSA? Yeah, so you will have more likely to have severe reaction to jaundice lah. You're more likely to cross blood-brain barrier, causing all these connectors lah. So if you see the weight is small, definitely moderate already. Cannot be low risk. Term baby, low weight, still moderate risk. Less than 2.5 kilo, I will always take moderate because they are small. So one of the possible causes is small for gestational age babies lah, because once the risk factor and then patient have that problem, the risk factor become the cause lah usually. This one it will not be listed in the cause, but when you see babies like this, I will put most likely the SGA babies causing this jaundice lah. Alright, they can be physiological lah, but I wouldn't put physiological as the cause lah if they are small. Okay, so SGA babies, prime babies, they want two separate cause lah, but the main thing is they are small. Okay, but prime babies, they are extra factor lah because they are premature, so your blood-brain barrier is much more vulnerable lah compared to term SGA babies. SGA baby, they are term already. Okay.
Less than 2 for the child.
Okay, you can, for prime baby we do the growth chart. see the plot, the growth, the height, the head circumference, the weight, see where it goes. If everything within the chart about the same, you put appropriate for external age. Okay. Anything below the graph, small lah. Anything above the graph for large lah. That one is more for prime. For term babies, we go by weight. More than 2.5 to 4 kilos, normal lah, AGA, appropriate. More than 4 kilos, low, large for gestation age. Less than 2.5, small. Okay. So that's why lah, baby yang 4 kilos and above kena monitor blood glucose lah, because they're big. Even though kalau you plot on the growth chart all these babies, somehow they fall under AGA lah. Even though they 37 week, 2.3 kilo, most probably will go under AGA, but by weight definition they are small. Okay, alright. Okay, next, what are the causes of jaundice? Berapa dah? Mana tak kira dah. How many you got already? Ten already. So another 5. Okay, the head. What can happen to the head? The scalp. Babies. Scalp.
Bleeding.
No, bleeding in the scalp ni apa? Yeah, kephal hematoma. That's another cause. Because got blood. If you got kephal hematoma, you can feel it, you can examine it, you can see it. Cannot be low risk already. They have to be moderate risk, because when the RBC breakdown, they will release your bilirubin lah. So jaundice will be high. So one of the causes kephal hematoma. Next, apa lagi? Scalp swelling in babies? Yes, hyponeuritic lah, or subgaleal they call it lah, because when you short form it, it become SAH. People always confused with subarachnoid. Okay. So, what are the difference between the two? Subarachnoid and kephal hematoma. This is another favorite question. Which one cross? Which one cross midline? No.
The subgaleal crosses the midline.
Yeah, subaponeurotic cross the midline because it happen at the caput can also cross, because the aponeurotic level is aponeurons layer, so it's everywhere. It doesn't bound by the sutures. Okay, so it doesn't bound by the sutures. It can cross all the sutures, cross midline lah. So when you have that SAH swelling, it will be boggy everywhere lah, and it cross sutures. So another feature is very boggy, tender. Baby can have hypovolemic shock because of it lah, because they lost HB. Alright. Sometimes very bad, it extend until the neck. It's so bad until it become like Mickey Mouse kind of thing. Alright. So if patient who are at risk SAH, vacuum delivery, forceps also can, but more likely in vacuum lah. Right? Even normal delivery also can have some small subaponeurotic hemorrhage. Okay, kephal hematoma, not tender. It fixed to the bone layer. Okay, so bone have sutures, that's why they don't cross sutures. And they most of the time very well rounded, easily defined shape. Okay, while caput is is edema of your skin, so skin goes everywhere lah. So caput basically is just edema of your skin area lah. So then the shape of the caput, it depends where that thing happen lah. It can grow sideways, it can cross horizontally, it can cross diagonally. So caput can follow the shape of whatever problem they undergo during delivery lah. So caput can have bleeding lah. It's either become kephal or they become SAH lah. So I wouldn't put caput as cause of jaundice lah. It's either kephal or SAH lah, because caput can become either two lah. Alright. Okay, so next. So baru 12 semua. Yes, the normal physiological jaundice. Don't forget lah, the physiology still can happen. Okay, alright. So if baby come very well, good weight gain, not much weight loss, breastfeeding well, good urine output. Those are the features lah. Then you send blood group okay, cantik je semua benda, HB normal, cannot find anything problem at all with the baby sama, but the photo level is still high lah, because your liver will take time to excrete the bilirubin properly lah. All this physiological thing will improve lah over time. So if you already check everything semua normal, cannot find the cause, yes, then you put lah physiological jaundice as a cause during discharge lah. Kalau during clocking, during admission, put lah in angel secondary to something lah, whatever lah, want to roll out ABO or whatever. Okay, alright, sama what else? Habis dah, baru 13 je, tak cukup. Tak cukup 15, rasanya ada lagi 2-3 kot, I can't remember also. Cuba Google apa lagi. Probably another two. Probably ada one or two yang quite important. Sekejap. Let me think about first. Because if you want to know jaundice, you have to know jaundice very proper. All the causes lah that can cause patient to have needing phototherapy lah. Okay, when you talk about dehydration just now, if the weight loss more than 10%, I wouldn't put the impression, the diagnosis as breastfeeding jaundice. I would put something more serious lah, like neonatal jaundice secondary to 10, 12, 13% weight loss. It give you more scare compared to breastfeeding jaundice. Make you a bit jumpy, right? Cause 13%, you want to monitor the weight, probably you want to send renal profile, you want to maybe start drip, bit of correction also. Okay, you want to check the breastfeeding tonic properly, refer to breastfeeding counselor and all that lah. So impression also important lah, even though it's breastfeeding jaundice per se, but putting the exact percentage is giving you lagi something lagi more important lah. Alright, so in the end, the important is taking history lah. Lately I don't see people take history lah properly. Another one more cause that people might overlook is mother taking certain thing lah, traditional medicine. Don't know lah what jamu, sinsai, ubat, whatever lah. So this traditional medicine, I don't know lah, it can cause for jaundice to be high lah. So it's very important to ask about history. Jangan ambil apa-apa something else lah. Makanan traditional. If got, then put it as the cause lah. That's probably the last one lah. So I say there's one more thing quite important to remember. So when you take history, the history, breastfeeding history, baby's well or not, urine output and all that lah, important lah. Then another some few factors why babies come with very high jaundice lah, especially coming from home. Why they come very high? Is it because not monitored? Mother delayed bringing child to the not counseled properly? If in the ward, you shouldn't be so high lah, because you should be monitoring, but somehow come with severe from home. You need to find out the reason lah. One of the reason, referral from the morning. You go to KK morning, right? Then malam baru datang. You delayed starting phototherapy. That's probably one of the reason. Mother stay far away also. Mother go back somewhere or drive here. All these thing very social problem lah. It will contribute to their treatment problem lah. Okay. So when you start phototherapy, how you want to start phototherapy? What do you need to determine?
The age of how many weeks.
Okay, so why do you need to know the age?
Because there's different thresholds for different weeks.
So, how many category of threshold?
That's in the PIDS protocol.
What did I say just now? Low risk, moderate risk?
High risk.
Low risk, moderate risk, and high risk. So, who are the low risk group?
Premature.
Who are the low risk group?
A low risk, sorry. Low risk.
Need to know low risk first lah.
Full term babies.
How term? 27 is term, but it's not full term. Full term is 38. 38 numbers is full term lah. So full term 38 weeker. Berweight more than 2.5 kilos. Even though it's not in the protocol, I still put it as 2.5. Okay, baby well, right? Baby blood group not O. Mother blood group is not O. Okay, then there is no other normal examination finding lah. Then you can put as under low risk lah. Okay, even though weight loss 7-8%, you still put as low risk lah, because dehydration is not, will not bring patient risk to higher risk lah. Okay, next moderate risk, 35 weeker to 37 plus 6 days lah. Those are low risk already. Then moderate risk. Then if ada satu term baby with 38 weeker with one risk factors, for example, got kefal hematoma, got ABO, okay, you have to bring the risk down to moderate lah. If 37 weeker but got GCPD deficient, high risk already. 35 weeker, GCPD deficient, high risk already. So high risk is 38 weeks with at least maybe two risk factor. Probably it's not mentioned. It's got so many risk factor, just bring down lah. Got sepsis, got kefal, got this, so even though term babies, be high risk straight away lah. Okay lah, kalau 37 weeker, 35 weeker got one risk, straight away become high risk lah. Okay, that's why prime babies always moderate risk lah. 34, 33. Okay, so then ABO, the swelling, sepsis, apa lagi? Prematurity lah. Those are definitely starting moderate already. So plus two risk factors become high risk already. That's how you determine lah. Okay, so when you start that one, you determine the level, then you see the age lah, the hours, how many hours of life. So usually less than 72 hours before day 3, you use hours. Day 1, day 2, day 3. Okay. So more after day 3, you can still use the hours up to day 5, day 6 lah. But most of the time by day 4, I started using days already. Okay, but in the protocol they use up to more than 96 lah. Okay, there are risk factors and all that all under it. Okay, so when you start photo, you want to know the bilirubin level at KK berapa, but you need to know lah KK level. Some KK they take serum, which is your blood vessel lah. Some take capillaries. There will be difference. If they take capillaries, they will not have direct level, but if they take serum, they will probably provide you with direct level lah. But if capillary level, you need to take one venous blood as well as a baseline. Then you start photo, then you monitor lah. So how frequent we want to monitor? It depends on the severity lah. If needing intensive photo, so in intensive photo, how do you determine patient need intensive or conventional phototherapy? So kalau the level is 50 above your starting photo level, so example your photo level is 250, baby's serum bilirubin is 320, more than 70, right? From photo level, start intensive loh. But it's not high enough nearing ET level. There are two levels you need to determine lah. You as houseman later on, your job find out the photo level, find out the exchange transfusion level, and then compare to the patient serum bilirubin level, determine need normal photo, conventional, or we call it single, or need double or triple photo lah, become intensive phototherapy. Okay, if nearing ET, I would repeat after 6 hours. If somewhere in between in between the ET level and just above photo level, once a day is enough. Coming morning lah, you do once a day. If very nearing ET, above ET, you do 4 hours 6 hourly until lah dia turun. Okay, so but those yang very high already, you send all the severe jaundice workup lah, mean prepare patient for exchange transfusion. The exchange transfusion workup, you need to send baby blood group, mother blood group, you send all those ABO, the retics, ABCs, send lah RP and all that lah. You in the end, if after 4-6 hours level still above photo, you need to proceed and get ET lah, if get consent from exchange. Even from the beginning pun very high already, you know, then you need to counsel them, this one might need ET. So after 4 hours when the repeat blood still there, you just have to request the blood by 1 hour, should be ready already lah. Okay, that's all lah about phototherapy for your thing. How frequent you need to monitor, then when to do ET lah.
Doctor, the exchange transfusion level is also there, is it?
Yeah. Nampak ada 2 level. You see?
If 70 above the photo level, then intensive.
Yeah. Okay. So 12 hours. Okay. For the normal low risk one, we probably remember already. By day 5, they should be 308. Moderate risk is 257. High risk is 208. Day 5. You see day 5? 308, 257, 205. That's by the time you remember already. It's always standard lah. Somewhere bawah-bawah tu you just minus 30, something like that.
Because this is 1 day of like 2 days.
Yeah.
For this 5 days.
So kalau for example baby low risk, photo level is baby come dah lambat datang, baby TSB level 450. You send away severe jaundice punya workup lah. But somehow after you shine 4 hours, they probably will come down lah. Most of the time will escape lah. But somehow if 500 like that, I'll straight away ET lah. I just from the beginning prepare for ET, but in the meantime you just shine lah. Shine first. Okay, but somehow some parents did not consent, cannot do anything lah. But you have to counsel properly lah. If you do not consent, why we do ET? The main thing is to bring down the level very fast, because we exchange fresh whole blood in baby's blood. You give blood with no bilirubin and take out blood with bilirubin a lot, so the level will drop by 100, 200 very fast. Okay, after 2 hours it will drop very fast. So when the level of bilirubin so high for so long, more likely it cross the brain, more likely it will lodge to your basal ganglia, causing interest lah. So you bring down faster, less likely for it to develop interest lah. Okay, but we don't know lah who gonna be interest or not. Even though they don't want ET, it will, if you put photo, for sure it will come down, but it will come down slower lah. Memang dia akan turun, of course dia akan turun. If you put shine after 1 day, 2 day, of course dia akan turun. But the thing, the exchange transfusion, we want it to
Faster.
go down very fast. That's the main aim lah. So when you counsel parent for ET, you probably counsel same also the risk as exchange as blood transfusion lah. Because you are basically transfusing blood, but on top of it you replace volume to volume. Mean you take out 10, you give 10. Blood transfusion you just give kan, tak ada take out, right? Okay, alright, 45 minutes already.
Oh wow.
Anything want to ask? Finish already.
For how frequent monitor?
Monitor, if the level is just above photo or just around intensive photo level, once a day is enough lah. But very severe, above 80 level, near 80 level, just do 6 hourly, 4 hourly. 4 hourly to probably above 80, you do 4 hourly already. But near 80, maybe around 6 hours lah, 4 to 6 hourly lah. Okay. So mean after you take blood, you start photo, you count lah from the photo time. You start pukul 8, you kira lah pukul 12, pukul 2, you need to repeat the blood already lah. Okay.
This more than 80 is the initial level serum.
More than 80?
More than 80 above photo level.
50.
Yeah,
For intensive photo, more than 50.
From photo to
Yeah. This is phototherapy. So what are the difference between the two level, conventional phototherapy and intensive phototherapy?
The wavelength.
The wavelength lah. One is higher wavelength lah. I think one is what? 220. The second one is 270, 280. About 50 difference I think. We check lah. I don't ingat the number.
So the decision to choose this doctor is based on
IPL lah, the intensive photo level. If the photo level is 250, serum patient bilirubin level is 320 at 70 above lah. So you need the intensive photo already. Okay, kalau photo level is 250, baby punya blood 270, single photo or conventional photo is okay lah. So this radiance need to check lah. There is a meter to check the radiance is enough or not. Enough meaning you put the conventional setting, the number reaching that 220 level or not. And then put the intensive, it reach the 270 to 80 or not. The nurse will have to do it every day lah. It's not your job. But your job is to check the book, see the level. If not, tak sampai then you bagi photo for nothing lah. Means that they're not giving their job properly. Of course, it will come down lah. We will count down very slow. If the number not good, then they have to change the LED bulb. Then baru after that they check lah. This one the engineering side lah. Sekali. Okay.
the 4 to 6 hours check is which one, doctor?
Near 80 or above 80 level. Kalau somewhere near photo intensive photo or just above photo level, no need lah. Once a day is enough. Sometimes I do twice a day if patient want to discharge early. Sometimes I do lah. Because most of the time the houseman will take bloods 4 a.m, 5 a.m. By the time you do around afternoon, 48 hours post the last blood. If level nearing, sometimes we discharge at least about 30 below photo level. 30 below photo level, then we discharge lah. But sometimes tak ada katil, as long as below photo level balik. Don't care already. Okay lah. Kalau discharge, then the thing you need to know when to repeat the blood. That's another knowledge that you all need to know lah. Kalau G6PD deficient, you got certain risk, please repeat blood next day. Kalau low risk, tak ada risk factors, physiological jaundice, repeat blood after 48 hours is fine. I mean, they have appointment lah. Okay. All these things is all inside protocol, you have to baca. So, I'm not giving you something new. If you hafal the PICS protocol, can pass PICS already. Or you can pass master pediatrics already.